Dr. Fernandez talks to us about behavioral health, the associated stigma, and the integrated behavioral healthcare model.
Podcasting from Dallas, Texas, I am Shireen, and this is the Yumlish podcast. Yumlish is working to empower you to take charge of your health through diet and exercise and reduce the risk of chronic conditions like type 2 diabetes and heart disease. We hope to share a unique perspective and a culturally relevant approach to managing these chronic conditions with you each week.
Dr. Pedro José Fernandez is an assistant professor in the Department of Psychiatry at University of Texas Southwestern Medical Center. He serves as co-chief of psychiatry at Parkland Health. Dr. Fernandez earned his medical degree at Boston University School of Medicine and holds board certification in addiction medicine and consultation liaison psychiatry. Welcome, Dr. Fernandez.
Thank you for having me.
An absolute pleasure. So, Dr. Fernandez, can you talk to us about why you decided to move into the field of psychiatry and how you became focused on behavioral health and cultural psychiatry?
Well, I think that's a really wonderful question. I will tell you, if you asked me 20 years ago if I was going to be a psychiatrist, I would have said no. Growing up, it took me a while to even figure out what I wanted to do. Options were kind of limited for me growing up. I was very fortunate to be able to get into medical school, but when I went into medical school, my concept of being a doctor was being that town doctor you see on television who's taking care of the community. And that's kind of what I kind of fell in love with. But as I was experiencing, rotating through different fields, I realized I was naturally gravitating towards mental health, and specifically the area of mental health that intersects with other areas of healthcare. So I kind of fell in love with, it used to be called like hospital psychiatry or consult psychiatry, psychiatry in these non-traditional spaces. Because I loved being able to kind of think of a patient holistically and think about all these aspects of care, both physical, mental, cultural, social, that kind of comes together. And then how you need to use that to help heal and work with the patient. So it was very quickly in medical school I say very quickly, but it was actually towards the end. But it was very quickly, once I realized what I wanted, that I switched gears and entered the field of psychiatry. And then specifically, the cultural aspect of it just came naturally, because you can't necessarily work in psychiatry and take this and be in this specific field without thinking of the cultural aspects of care.
Can you help us understand what cultural psychiatry is?
It's a hard term to describe, mostly because, there's so much work around it and it spans, decades. But cultural psychiatry essentially is just thinking of psychiatry and mental health through cultural lens and understanding how individuals' experiences, community, culture influence both the expression of mental illness and actually a treatment of mental illness. I think psychiatry very early in the field just kind of focused on one population, and a lot of our manuals of diagnosing illness and conditions were really based on this one population. But even just in the last few decades, we've really grown in understanding that how culture impacts biology. And not just that, how culture impacts how we express symptoms, how we seek help, and how we respond to treatment. So I think cultural psychiatry kind of encompasses all of that. And really, it's psychiatry, but it is still kind of that term where we're trying to move the field that 5 years in the future, you're not going to be asking me, hopefully, what cultural psychiatry is, because all of these aspects will be incorporated in just psychiatry.
Absolutely love that approach. I want to circle back to cultural psychiatry and also some things associated with that. First, I want you to help us understand the correlation between diabetes or a chronic illness and depression and really trying to understand what that connection is, which one causes which one, and how they're related.
So, both diabetes and depression are both chronic medical conditions. And they're actually chronic medical conditions that have high overlaps. If you look at the literature, there's some statistics that show up to 1/3 or half of patients with diabetes also struggle with clinically relevant depression. And how these two conditions intersect is really interesting. Both diabetes itself as an illness could help contribute to individuals' vulnerability for depression, both biologically, but also how diabetes impacts life and social function. I mean, having diabetes, especially if you're thinking of type 1 diabetes, you're tied to doctor's appointments, you're tied to checking your sugars, you're tied to insulin. And especially if you develop that earlier on, you're more predisposed to having stress that could contribute to depression. And then depression itself could impact diabetes care. When someone's depressed, they oftentimes don't eat the most healthiest food. They oftentimes are not exercising. They're not on top of their health or wellness. Depression is one of those things that becomes this insurmountable beast at times, where even simplest tasks are very challenging. So if you have diabetes and depression, you could see how that could then really severely impact your overall course in diabetes. And then that ends up being this vicious cycle where the more uncontrolled your diabetes is, the more it could contribute to depression, then vice versa. The more you're depressed, the less likely you might adhere to diabetes treatment.
Now, I want to go back to the cultural psychiatry piece and understand stigma around mental health. Can you speak to the stigma associated with mental health and what is really being done to overcome it today?
Stigma is a huge issue for mental health. And I think it's prevalent in all the communities. Especially, it's much more prevalent in communities of color. I myself am Hispanic. I'm actually an immigrant to this country, and I could speak firsthand how I've seen family members, loved ones, friends kind of growing up. The stigma and the misconception of what mental illness is and what seeking mental illness treatment can mean. And it really impacts folks' ability to kind of seek care and accept care. And it's really challenging because it ends up becoming and contributing to a silent epidemic where folks are struggling and suffering, but just not talking about it. And then the community doesn't talk about it. So it's a huge public health challenge. There's a lot of ways to try to overcome it. And I think kind of one of the biggest ways of approaching it is, first of all, just understanding the communities. An approach in one community is not going to be necessarily relevant in all other communities. So you need to kind of get to know the patient population or the population you're working with, get to know them, and also hopefully get their investment. And, one of the most popular ways to try to kind of overcome stigma is working with the culture itself, essentially having community members, engaging key members of the community, whether it's church figures, whether it's kind of whatever important figure with us in the community, to be more open in discussing it. I think when individuals see others, especially other people that they have in high regard within their own community talking about it, that's a really good way of destigmatizing it. Other ways of approaching it is even just changing the way that we're providing and allowing folks to access care. For some ways, some individuals identifying that they have mental illness and then seeking mental illness is challenging because they don't want other members in their community to know. I think sometimes it's important to create a safe space that they could seek treatment anonymously. Obviously, that's not a quick fix to the solution because ultimately we want to destigmatize it by making it more publicly accepted. But I think in the early stages, you need to kind of allow that avenue for folks to kind of seek care that way.
I love that approach. And I was also going to ask you, what are you seeing or what can health systems broadly do to address mental health? I know Parkland Health is doing some interesting work there. Can you speak to some of that?
Yes. So, we're using a lot of those same principles. So Parkland Health in association with the Dallas County, City of Dallas, we implemented a community health needs assessment, which I think is a really wonderful initiative. They've done this a few times before. The latest one was in 2019. And essentially what the Dallas County CHNA has done is identify populations at risk due to prevalent health disparities, as well as medically underserved areas within the county. So, we have many residents in Dallas County, especially in geographical vulnerable areas, that don't receive adequate medical care. And that could be results to multiple factors. Either they're uninsured, financial, transportation, socioeconomic barriers, but it really makes it difficult for them to maintain their health. So they did this very extensive assessment. And one of the most important keys to that assessment was bringing in community members to speak on their own behalf of what they see in their community and what are the needs they have. I think if you ever do these initiatives and don't include the community you're working with at the table to kind of advocate for what they need, you're going to be less successful and you're really not going to do a good job. Parkland and City of Dallas, they did that. And I think their voices really impacted the information we obtained. And then ultimately, it's using that information to do a comprehensive plan, an implementation plan. So that's something that we did. Ironically, if you remember back, I said this happened in 2019, which we're all still living this. This was right before the COVID pandemic. So when it came to the implementation plan, that was at the very beginning of the pandemic. And if you could imagine, the hospital system, the community, the nation had a lot of things to tackle at that time, which was very overwhelming. But you could see Parkland's commitment to this implementation plan because nothing slowed down. We continued to dedicate our resources in rolling out and addressing these healthcare disparities and health needs in the community, despite our own struggle with dealing with COVID, surge plans, and all of those other things. So I think not only is it doing the assessment, having a good implementation plan, and both of them should also have a voice from the community, but ultimately is maintaining that commitment despite all these other factors that came.
I appreciate you sharing that and really setting the stage for what other health systems can do to really address and first understand the needs of the population that they're serving and then start to address them. You mentioned earlier, as we were talking about the stigma associated with mental health in particular, in an earlier conversation, you had talked about how just taking the approach of a diabetes clinic that also provides mental health, services has been very unique in terms of the way people are open. And again, going back to the stigma of it, but being open to getting the help that they need. Can you first tell us about the problem that you saw and then how you went about overcoming it?
So let's see, like I already mentioned, there's this huge overlap of diabetes and depression, and not just depression, other mental illness. There's anxiety, and there's also other folks with chronic mental illness that actually develop diabetes because of even the treatment for chronic mental illness makes them vulnerable to developing metabolic syndrome, weight gain, and diabetes. So that's the big problem. And how do you best address this? Because both could be very challenging. Addressing and treating diabetes is challenging, and then addressing and treating mental illness is challenging. So we tried various approaches. I think at one point we brought in diabetes care into our behavioral health spaces. And I think that was a really good first step. I think that was an acknowledgement of these are two conditions that we need to be able to work together, diabetes and mental health, to be able to address it. Because working in silos is not going to be effective. The problem with that is, and I think it fell back to stigma, a lot of folks still have stigma in accepting and accessing mental health. So even just coming into a behavioral health clinic, a psychiatric clinic could be challenging. So we changed the approach and we flipped it. So we actually partnered with our diabetes team, which, by the way, we have a strong relationship between our diabetes teams and behavioral health team here. they really get it, which is one of the hardest challenging of implementing any integrated system, having invested and kind of advocates on both sides. But they really got it. So what we did is we started to introduce mental health services in the diabetes clinic. So when someone went in to see their diabetes doctor to have routine diabetes care, their doctors and providers would identify this is someone that also is struggling with mental health. And they would just put in a referral or even walk the person over to our provider. So we started by having a psychiatrist there. And then we quickly identified that we needed more services. So since then, we've also added a therapist. And I think it's really been really wonderful because then those behavioral health members actually not only are able to kind of address these needs, but they also are able to help destigmatize it. Because not only is it really easily accessible, they're also receiving it in their diabetes treatment. So it just really normalizes it. Addressing their behavioral health becomes just like addressing their blood pressure or addressing other chronic medical conditions. So moving it together just, again, destigmatize it, makes it accessible, and improves coordination. One thing I want to mention about that is also really, I think is really wonderful, is the fact that how both providers could even help support. You have the diabetes doc helping to encourage the individual in seeking mental health treatment and actually sticking to the mental health treatment and vice versa. The mental health provider is then able to reinforce the need of appropriate diabetes care and sticking to the treatment. So they work really wonderfully synergistically.
Thank you for sharing that. I do want to turn a little bit to your recent publication, your research. Your most recent publication is about integrated behavioral health care, IBHC models, and benefits of implementing them in existing healthcare systems. Can you tell us what IBHC models are and how implementing them can meet needs in today's healthcare systems?
Okay, so integrated behavioral health care is a catch-all term that encompasses all models of care that involves bringing in mental health services in medical clinical spaces. So traditionally it's primary care, but you could also think of integrated behavioral health in, like I just mentioned, in diabetes or in HIV or in other medical clinics. There's a lot of different models out there, but what's been really consistent that by and large, these models are really successful. In general, and as I'm going to focus right now in primary care, the majority of folks that receive mental health treatment in the country right now receive the treatment through primary care. And oftentimes, primary care physicians aren't really equipped or supportive in providing effective mental health care. Not only that, but the majority of folks who could benefit from mental health services don't ever seek mental health services, but they do pass through primary care. So that really creates a really wonderful opportunity to have a better impact on individuals' mental wellness by bringing in the services there. So kind of what I described with bringing in mental health services into diabetes, it's the same approach of bringing in mental health services within primary care, where you oftentimes, and there's different models and different approaches of how they go about it. Some models that rely on social workers, nurse practitioners, psychiatrists, psychologists, but at the very heart, it's the guiding principles of having structured unified screening for mental health, making it an accountable care system. So having ways of tracking patients and also tracking outcomes, and also implementing evidence-based care.
I do want to tie this back to cultural psychiatry. So how could IBHC models potentially help patients from a cultural psychiatry perspective?
So there's a lot of benefits to it. But I think one of the biggest benefits to it is that, one, it makes seeking mental health treatment much easier for underserved communities or communities of color. I mentioned stigma. Stigma is always so challenging, but stigma is easier to surmount when, one, you normalize the experience, and two, you just make it a little bit more easier to access. So one, bringing in mental health within the primary care setting just automatically normalizes it. When I worked as an integrated psychiatrist, I would be seeing patients in the same room as their primary care doctor. So the image people have of a psychiatrist with a couch and a nice lighting, I was right there with the exam table. I had my nurse and people rooming patients in and out. So the primary care doctor walked in, they walked out, and I'm coming in and coming out. So it just makes it just more normal and easier to accept for folks. And then two, it is very challenging to engage folks in accepting mental health treatment, but people by and large trust their primary care doctor, especially if you have that good relationship. I mentioned I wanted to go into medicine because I wanted to be them, right? I wanted to be that community primary care provider. So we naturally, hopefully, have this trust towards them. So it makes it much easier to then have that person talk to you of saying, I notice you're struggling. I know you might not feel comfortable meeting with someone or trying out this medication or trying out therapy, but you know what? I have this one person and he's just down the hall and I could just bring him in right now and you just need to meet him once and just say hi. If you don't feel comfortable, you don't have to go back. And you'd be surprised. And that's called a warm handoff, where you have one provider bringing in another provider in the same room with the patient and introducing themselves. And it's funny, just that human contact just makes it much easier for that patient to say, you know what, I'll see you. I'll give you a shot. Especially, again, it's in this environment.
Absolutely love that. Do you see any other challenges outside of stigma? Any other challenges in the implementation of the IBHC model, and how could those be addressed effectively?
The biggest implementation barrier is funding. At the end of the day, IBH models, I'm going to put on my administrative hat. IBH models, unfortunately, aren't direct revenue generators for large hospital systems. And I think that's, by and large, has been a challenge. In general, mental health providers, we don't really generate a lot of revenue. So a lot of systems, even though it is really important, a lot of systems might not invest sufficiently in mental health services. Luckily, there's a lot of things coming out. So Medicare has approved collaborative care codes, which allow primary care providers to bill for some of these services, which help offset the cost. And there's a lot of other analysis out there that shows that if you implement IBH models, specifically collaborative care is a specific model within that big domain of IBH. But if you implement collaborative care, for example, you have significant impact on decreasing cost by improving overall health. So, if you are appropriately treating someone's mental health, they're more likely to adhere to their diabetes treatment. They're most likely to adhere to their hypertension treatment. They're less likely to require higher levels of medical care, emergency room, medically hospitalized. And that actually saves systems money. So there's all this literature to support it. But at the same time, it's still a struggle in a lot of institutions to implement these models because, again, the financial barrier.
Interesting. And it's really about having the foresight to see the investment dollars today have a huge ROI sort of downstream. So with that, Dr. Fernandez, we are toward the end of the episode. At this point, how can our listeners connect with you and just learn more about your work?
So, I would point your listeners to kind of two major sources. One is Parkland Health, and the other one is UT Southwestern. Both institutions are doing really amazing work and innovative work regarding healthcare and especially mental health care. So I think that would be really wonderful resources for your listeners.
Lovely. And for our listeners, after this episode, head over to our social media and answer this one very simple question. What is the one thing you could do or are doing to improve your own mental health? If there are things that you are doing, share with us on Facebook, on Instagram. Head over, find the podcast post, and let us know what is the one thing that you could do or are doing to improve your mental health. And we'll see you there after the episode. With that, Dr. Fernandez, it's been an absolute pleasure. Thank you so very much for your time.
Thank you. And I really feel appreciative to be able to speak to you and your listeners.
Thank you for listening to the Yumlish podcast. Make sure to follow us on social media at Yumlish_ on Instagram and Twitter, and at Yumlish on Facebook and LinkedIn for tips about managing your diabetes and other chronic conditions, and to chat and connect with us about your journey and perspective. You can also visit our website, yumlish.com, for more recipes, advice, and to get involved with all of the exciting opportunities Yumlish has to offer. If you like this week's show, make sure to subscribe so you can hear more from us every time we post. Thank you again, and we'll see you next time. Remember, your health always comes first. Stay well.